TBL?
Good.
Good, very good or good?
Very good.
Good. You guys need to be more careful about TBL because there were students who actually passed the courses and failed because of TBL. Because, they add TBL later after you pass, but for someone they add TBL because they did not do well, you end up failing the whole course. And this block, there is only 2 TBLs, right? So 5% and only 2 TBLs. Plus you will get used to the questions that we ask, the style and all of that. So you need to be careful with the TBLs and more attentive. Okay, so today we'll discuss the pancreas and the small intestine. Okay, what is the pancreas?
Gland.
Gland. What type of gland? Exocrine.
Both. Mix.
So what's the difference between exocrine and endocrine gland?
Endocrine is in the blood.
Doesn't
Through
have
the
duct,
blood.
it's like dirt.
Endocrine is in the blood. Exocrine is in the ECF.
Yeah.
In the what?
ECF. Extracellular.
Okay. Did you get it? So exocrine gland, give me example of, what do they produce, the cells? Saliva from the pancreas?
No.
MashaAllah. So you have your pancreas here in your mouth.
Insulin and glucagon.
Glucagon is an exocrine function?
No.
Endocrine.
Yeah, pancreatic enzymes, the pancreatic enzymes needed for
Digestion.
digestion. So we have to carry them where?
Duodenum.
Well, yes, you have to make sure that they reach the intestine. So we have to have a duct. While the endocrine function, like they secrete what? Insulin, beta cells of Langerhans, and glucagon, for example, which is the opposite function of insulin, from alpha cells. That goes into the blood directly, so you don't have to have ducts collecting, insulin and glucagon, right? So it is both an exocrine and endocrine. What are we looking at here? What do you see? What do you see?
Pancreas.
So what are you looking at?
Pancreas.
What do you see?
Pancreas and
I know, this is pancreas, the topic of today. Now we're looking at structures sitting on the anterior. This is the anterior abdominal wall. Where is the posterior?
Posterior.
no, anterior to the pancreas.
So this is the posterior abdominal wall, and you have number of structures sitting on the posterior abdominal wall. And these structures here that you see in the picture are retroperitoneal structures. What do you mean by retroperitoneal structures? Behind the peritoneum, meaning that it's like a towel. Peritoneum will come and cover them on top and maybe on the sides. As opposed to what? Intraperitoneal structures like what? Stomach is completely wrapped by peritoneum, so that's intraperitoneal structure. Okay, small intestine completely wrapped by peritoneum. Liver completely wrapped by peritoneum. But for these structures, they are retroperitoneal structures. Today's topic is about the pancreas. These are the retroperitoneal structures. You have the pancreas, you have the duodenum, right? You have both kidneys, you have the ascending colon, you have the descending colon, the inferior vena cava, you have the aorta, and what are these muscles? Psoas muscles. Okay. So pancreas is one of the retroperitoneal structures sitting on the posterior abdominal wall, except for the tail. The tail, you can see the pancreas extending from it is actually hugged by the duodenum. This C-shaped structure is the duodenum. Okay, so it's going to extend from the duodenum all the way to the spleen. This is the spleen, this is the kidney, and you can see the tail is actually going, there is a ligament between the spleen and the kidney. Peritoneal ligament. What do you mean by peritoneal ligament? You had a lecture on peritoneum. What is it?
Double fold.
Don't say a word till the end of the lecture, okay? I give others a chance. What do we mean by peritoneal ligament?
The ligament itself?
Yeah, this is the peritoneal ligament between the kidney and the spleen, splenico-renal or lieno-renal ligament. What do you mean by peritoneal ligament?
Holds the organs together.
Give me examples of peritoneal ligaments. Falciform ligament. What is a ligament? It's a two-layer fold of peritoneum. Simple. So this two-layer fold of peritoneum can be either a ligament, which is this case, falciform ligament 2, or mesentery, or omentum. So whenever you have a two-layer fold of the peritoneum, it's either a ligament or a mesentery or omentum. So in this case, this is a ligament between the kidney and the spleen. It's called the splenico-renal ligament or lieno-renal ligament, and the tail goes inside between the two layers. So it means the tail is not retroperitoneal, it's actually sandwiched between the two layers of the peritoneum, so it is an intraperitoneal structure. So when we say that the pancreas is retroperitoneal except for the tail. Now, pancreas, they say it is located on the transpyloric line or plane. You had a lecture on the anterior abdominal wall? Yes? No? What is have you ever heard of what is it? Yeah, we say it is transpyloric, meaning it's going to go through the pylorus of the stomach. That's where we get it. And it's going to start from the tip of the ninth costal cartilage to the other tip of the ninth costal cartilage. Okay? While passing through the pylorus of the stomach. And basically it is, this is the xiphoid process. It is a hand breadth below the xiphoid process, or half the distance between the umbilicus and the xiphoid process, something like this. This is the transpyloric plane or line, tips of the ninth costal cartilages. Okay, it is about hand breadth below the xiphoid process, or middle way between the xiphoid and the umbilicus. Okay, but it goes through the pancreas as well, and that corresponds to which level of the vertebra? L1. How many vertebrae do we have? How many cervical? 7. How many thoracic? So we say T1, T2, T, and then how many lumbar? 5. How many sacral? 5. And then we have coccygeum, right? So we number them. This is T1, T, and then we use them to say the levels. This is at the level of T1, this is the level of T5. The transpyloric plane is at the level of L1. Okay? So, and you can see that the pancreas extends from them. As I said, it is hugged by the duodenum. So from this C-shaped structure is the duodenum. It goes from the duodenum all the way to the spleen. Okay? And it has different parts. It has a head between the arms of the duodenum, and then it narrows a little bit, becomes the neck, and then it is the body, and eventually it is the tail. Okay, so this is the head of the pancreas between the arms of the duodenum. So what do we have anterior to the pancreas? The head of the pancreas. We have the transverse colon and transverse mesocolon. What is transverse colon? You know what is transverse colon. What's transverse mesocolon? It is a mesentery. What is one condition that we have to have for it to be a mesentery? Any mesentery?
It attaches to the posterior abdominal wall.
This is the last time I'm allowing you. Fine. You're Masha. What's your name?
Mishal.
Masha. Your name? Okay. So one condition for it to be a mesentery has to be attached to the posterior abdominal wall, because, and we have mesenteries for long structures. Small intestine and transverse colon is long. You cannot afford to have it floating in the abdomen, so you attach it to the posterior abdominal wall. Line of attachment of the transverse mesocolon passes actually across the pancreas. You can see this line here, and this part of the duodenum, the second part of the duodenum. So when we say anterior relation of the head of the pancreas is the transverse colon and the transverse mesocolon. And posteriorly, if you were to flip this, okay, what do you see passing behind the pancreas? This green structure is the common bile duct. If I let this go back, it's going to be the pancreas. The head of the pancreas is going to be in touch with this. What is that? The inferior vena cava, and this is the right renal vein. But before we proceed further, a little extension of the head is going more towards the left. We call that the uncinate process. The uncinate process, like this. This little extension of the head going to the left is called the uncinate process. How do I know where the uncinate process is? You can see it crossed by these structures. What are they? These are the superior mesenteric blood vessels, artery and vein. So the superior mesenteric blood vessels, they cross the uncinate process, and they cross, what is this? This is, the third part of the duodenum. And, it is usually the uncinate process and the duodenum that will separate them from the aorta plus the left renal vein. So anyway, this is the head. Anterior to the head, the transverse colon, transverse mesocolon. Posterior to it, we have the bile duct, inferior vena cava, right renal vein. And then after the head, we have a little constriction. That is the neck. It's about 2 centimeters. How do I know where the neck is? Basically, it is behind the pylorus of the stomach. Okay, so anterior to the neck is the pylorus of the stomach. Everything is written. Don't have to write anything. Okay? What is posterior to the neck, which is important? We're going to discuss that. Today there was a question about portosystemic anastomosis, but you're going to discuss that in details. Anyway, behind the neck, that is where the portal vein is formed. You know what is portal vein? We have 2 venous systems, right? Systemic and portal. Why do we need a portal? It absorbs, it takes whatever nutrients, after digestion, all the nutrients that's needed will be taken by this portal vein, and they will send it to the largest factory of the body. What is the largest factory of the body? The liver, right? So portal vein or portal venous system is basically the venous system responsible for taking nutrients from the gastrointestinal system to the liver. Okay, this is the portal vein. It is formed by a junction of splenic vein, and this vein is called the superior mesenteric vein. I'm going to study that in details. Okay, so the neck of the pancreas is actually in front of that. So this is the neck because it is in front of the where the portal vein is formed, and anterior to it is the pylorus of the stomach. And then we have, after that, the body. Body, if you cut it, it's going to look triangular. If you cut the body and look at it from the side, it's going to look triangular. Okay, so it has an anterior border, superior border, and inferior border. Now, For the the superior border of the body, what do we have related to it? This artery. This huge, thick, tortuous artery. Once you see, you will never forget. This is called the splenic artery, and they say it is dancing on the superior border of the pancreas. So this is the splenic artery. It is coming from the celiac trunk. Right? So this is the splenic artery going towards the spleen. As it goes towards the spleen, it's going to supply the pancreas because it is dancing on the superior border of the pancreas. Anterior border, you have again the transverse mesocolon. That is the attachment of the transverse colon to the posterior abdominal wall. Anterior surface, what do we have anterior to the pancreas? What is this? Stomach, and between the stomach and the liver, what do we have? Lesser omentum. Behind both, what do we have? Lesser sac. What is a lesser sac? So we have lesser sac, which means we have to have greater sac. What are they? Peritoneum? Sacs. What are they? Space, right? Between visceral and parietal. What is parietal peritoneum?
Away from the organ of the body.
Posterior wall.
You had a lecture on peritoneum. What is the parietal peritoneum?
The one covering the body wall.
The one that covers the body walls. The one peritoneum on the walls, we call that parietal. Peritoneum on the viscera? Visceral, right? The space between peritoneal cavity. What do we have in there? Peritoneal fluid, few millimeters peritoneal fluid. How many organs we have in the peritoneal cavity? None, because simply it is the space between visceral and parietal peritoneum, right? So the peritoneal cavity is divided into lesser sac and greater sac. Lesser sac is basically a space hidden behind the stomach and the lesser omentum. Why do you need a space behind the stomach?
Remove feeling.
For protection.
Distension.
Peristalsis to accommodate food.
Accommodates what?
Food entry to the stomach so we can expand. Maybe the churning of the stomach to provide the space. During peristalsis it moves.
What's your name?
Farah.
Farah, and the other
Rama.
Rama. Yeah. Why do you need a space behind the stomach? What is the stomach? It's expandable organ. So imagine you eat a kharoof, for example. You need space for the stomach to expand. That is what the lesser sac is there. It is behind the stomach, and it's just to give the stomach a space to expand. So that is the lesser sac. The rest of the peritoneal cavity is the greater sac. Okay. Anyway, so anterior surface, anterior to the pancreas is the stomach and of course, the lesser sac. And posterior to the pancreas, we have this structure, the portal vein, we have the splenic vein, we have the inferior mesenteric vein, we have the aorta, and we have the left kidney. What else? Blood supply. Of course, it's going to be receiving branches from the splenic artery, dancing on the superior border of the pancreas. But not only that, it's going to receive the superior pancreatico-duodenal artery. Why do we say superior? Because we have inferior. Now the superior is going to come from this. This is the celiac trunk. It's going to give us hepatic artery. It's going to divide into two. One goes up, hepatic artery proper. One goes down. It's very important, extremely important artery. They will always ask you about perforation to the gastroduodenal artery. But gastroduodenal artery will give us the superior pancreatico-duodenal artery or arteries. Sometimes it's one, sometimes and divides into two, sometimes two separate ones. They ride the pancreas like this. One anterior to the pancreas, one posterior to the pancreas. So the superior pancreatico-duodenal artery comes from the this, the hepatic artery, and the inferior one is actually going to come from the superior mesentery. I'll have a full lecture on the blood supply. I'll make it easy for you. Veins, they correspond to the arteries, and they will drain into the portal circulation. Okay? Now, when it comes to lymphatic drainage, what is the general rule I told you about in the CVP? I did not teach you. You follow the arteries. If you're in doubt, you can blindly say lymphatics will follow the arteries. Okay? So what is the lymphatic drainage of the pancreas? Let me see. The splenic artery. So splenic artery comes from the celiac lymph nodes. So it's going to drain into the celiac lymph nodes. Superior pancreatic, also celiac lymph node. It's going to go. Inferior pancreatic duodenal to the superior mesentery, right? Superior mesenteric lymph nodes. And you apply this with very few exceptions. Follow the arteries and then you will see where the lymph nodes are. You don't have to memorize them individually. Nerve supply, all organs are supplied by autonomic nervous system, right? What do we have? Sympathetic, parasympathetic. Sympathetic, what does it do? Generally speaking, fight or flight, right? So when you're fleeing something, more blood will be going to your skeletal muscles. You don't worry about digestion and all these things. Your pupils will be dilated and so on. While parasympathetic is when you're sitting on the beach, relaxing, eating ice cream, right? But, sympathetic and parasympathetic. Parasympathetic mostly for, 75 of parasympathetic of the viscera comes from the vagus. Sympathetic, they come from the spinal cord, right? Thoraco-lumbar, from the thoracic spinal segments and lumbar spinal segments. Okay, from T1 to L2. But now you have sympathetic fibers sitting, or neurons sitting in the spinal cord, and they want to reach to the organs. How do they do that? Yeah, most of them, they actually go with the spinal nerve. Some of them, they go directly. But this is not the point. Do you know anything about the referred pain?
Yes.
What is a referred pain? What is the concept of referred pain? What is a referred pain?
It's not directly affected of the area of this pain, so
Yani, more. And would you be able to say, oh, I have pain in my appendix? I have pain in my kidney. I have pain in my heart. I have pain in my ureter. You cannot. How frequent you have pain from your heart?
It's like a source of injury or disease
No.
in the dermatology.
So,
Pain in the skin.
the good, no, it's not pain in the skin.
Injury.
يعني
Injury by pain.
صبرك أنا مو injury. إيش اسمك يا بنت؟
رهب.
رهب عصبية يا رهب. Take it easy. Here, if you understand that, pain fibers from these organs, how do they reach the spinal cord? For you to be able to interpret pain and other sensation, it must go to your central nervous system, which is the spinal cord and the brain. How does it reach the spinal cord? And you have pain fibers coming from pancreas. How does it reach the spinal cord? They hitchhike with the sympathetic fibers. If the sympathetic fibers are coming from T5, T9, so the pain fibers from the pancreas, they're going to go up with these sympathetic fibers, and guess where they're going to go? Which spinal level? T5 and T9. But your brain is not going to think that the pain is actually coming from the pancreas. You don't get this every day. What do you get every day? You get pain from the outside. So your brain is going to think it's coming from the outside. What is the area on the outside? We call them dermatomes, supplied by T5 and T9. It is actually below the umbilicus, T5 and T9. So pain coming from the pancreas is going to be interpreted by your brain as if it is coming from the outside. Where is the area of T5, T9? This is the area of T5, T9, and on the back. This is the concept. You don't say, I have pain from my heart, right? So you have pain on the left side radiating to the shoulder, right? Because the pain fibers from the heart hitchhike with the sympathetic nerve fibers supplying the heart, and it's going to enter specific spinal cord segment. So your brain is going to say, it's not going to say, oh, I have pain from my heart. You don't get this every day, but somebody might hit you every day on the chest, right? So it's going to say it's coming from the outside. This is the concept of the referred pain. So when I teach you the nerve supply of an organ, doesn't matter. I'm always going to say sympathetic, parasympathetic. Simple. Most of the parasympathetic is going to be vagus. What do they do? Abdul Jabbar, Abdul Ahad, and Angelica will come and tell you what will sympathetic. But for us, what is more important, you have to remember that the pain fibers, they hitchhike with the sympathetic, and they will enter the same spinal segment. So the pain will be interpreted as if it is coming from these spinal segments on the outside. We call them the dermatomes. I always think I taught the CVP. I always explain this in the... Anyway, so pancreatic ducts. Again, pancreas is an exocrine and endocrine gland. Exocrine, you have to collect the pancreatic juice and send it where? To the intestine, so that it helps, it aids in the digestion. So we have a main pancreatic duct of Wersang, the guy who discovered that, and you can see it coming from the tail all the way there with little ducts, Sometimes some of us will have an accessory pancreatic duct of Santorini, probably an Italian guy. It's not in all of us, and it mostly drains the area of the head and neck. Sometimes it communicates with the main one. But the duct of Wersang does not open into the duodenum alone. So what's its approach is the duodenum, it combines, it joins the, what is this? The common bile duct, which is coming from the gallbladder. Okay, and they will form a single canal, the hepatopancreatic ampulla because it dilates, of Vater, the guy who discovered this. Okay? So, bile is coming from the gallbladder. Why do we need bile? Digestion of fat, right? And pancreatic juice will come together and they will open into the second part of the duodenum. Okay, both of them, when they form a single canal, they are surrounded by a sphincter. It's called the sphincter of Oddi, O-D-D-I. Now, each of them will have its own sphincter, but on top of that, you will have another sphincter of Oddi. So whenever, you have your cells sitting in the mucosa of the intestine, enteroendocrine cells, they sense you ate a fatty meal, they secrete a CCK hormone, goes to the liver, it goes to the gallbladder, contraction, and will relax the sphincter of Oddi. So bile and the pancreatic juice can go inside. Sometimes, what do we know about gallbladder? It's a very common thing. Stones, right? 4Fs, female, 4T, fair, fat. Typical patients of gallbladder stone. Anyway, so if there's a big stone that comes down here and it stops there, that's going to prevent the pancreatic juice from entering the stomach. That might result in pancreatitis, inflammation. Itis means what? Inflammation, right? Pancreatitis and so on. Anyway, so this is the pancreatic duct. This is the common bile duct. They join forces, become a single duct, the hepatopancreatic ampulla of Vater, and they are surrounded by sphincter of Oddi. Now, when they enter into the duodenum, they're going to push the mucosa. So they create something like, a ball, tiny little ball. We call that major duodenal papillae, just an elevation of the mucosa. Sometimes if you have Santorini duct, which is the accessory pancreatic duct, it opens about an inch above the major one, and it is a tiny little one, so it's gonna create a minor duodenal papillae. So basically it is nothing but the bulging of the ducts into the mucosa of the duodenum. Now, small intestine, what do you have in your tummy? You have 6 to 7 meters of small intestine. 22 feet. 6 to 7 meters, imagine. And then you will have 2 meters of the large intestine, all floating in your abdomen. Today we'll discuss only the first part of the small intestine, which is, what are the parts of the small intestine? That is the duodenum, and then jejunum, and then ileum. Next lecture, I'm going to tell you how to differentiate between the jejunum and the ileum. If you're operating on ileum, you're not going to pull the 7 meters so that you know where the ileum is, right? But we'll teach you the differences. But today we're going to discuss only the duodenum, which is the first 10 inches only. 10 inches, how many centimeters?
22.
Why 22? 30? 25. Each inch is 2.5 centimeters. Anyway, and then when we say peritoneum is one of the, duodenum is one of the retroperitoneal structures discovered by peritoneum anteriorly, with the exception of the first part of the duodenum. See, duodenum has 4 parts. First part, 2 inches. Second part, 3 inches. Fourth part, third part, 4 inches. And the last part is only 1 inch, right? So the first part is 2 inches. The whole duodenum is retroperitoneum, with the exception of the first inch, not the first part, the 2 inches, only the first inch. Why? Any guesses?
It's connected to the part of the stomach.
Okay, you don't know. What is this? Lesser omentum. What is lesser omentum? It's a 2-layer fold of the peritoneum between the
Liver.
lesser curvature of the stomach and the first inch of the duodenum and the liver. So we will have the gastropancreatic part, and we have the hepatoduodenal part. So this part actually goes and it wraps the first inch of the duodenum. So the first inch is not retroperitoneal. What do we have in this? If I open this, what do I see in the hepatoduodenal ligament? Bile duct, portal vein, and hepatic artery proper. Excellent. And what is this? What is epiploic foramen? What is it? You think I can put my fingers in the epiploic foramen, or it's going to explode? You can? Can. Huh? And you can hold these structures in the hepatoduodenal ligament if you need to block them temporarily, right? But it is the entrance into lesser sac, right? What is behind the lesser omentum? And the stomach is the lesser sac. The entrance into the lesser sac is the epiploic foramen. So if I were to open this, what do I see? You see the bile duct, you see the hepatic artery proper, and the blue one here behind is the portal vein. So the first part of the duodenum is 2 inches. What is anterior to the first part of the duodenum? For it to be able to see it, you've noticed that we had to lift the, what is this structure? What is this? Liver. So we have to lift the liver. If I let the liver go down, right? So the liver will be, and the gallbladder will be in touch with the first part of the duodenum. This part of the liver is called the quadrate lobe. We're going to study that later on. And this part of the gallbladder is the neck. This is the fundus, this is the body, and this is the neck. So the quadrate lobe and the neck of the gallbladder are going to be in touch with the first part of the duodenum. What do you think is behind the first part of the duodenum?
The portal and the
You know, these structures.
yes, the portal.
This green is going to continue, which is the bile duct, and the blue, the portal vein is there also. And this one, branch of the hepatic artery that goes behind the first part of the duodenum, the gastroduodenal artery. Why it is important? What is the commonest site of duodenal ulcer? Is the first part. Why? Because you have high acidic content coming, gushing, and it will hit the first part of the duodenum before it is neutralized by the alkaline secretion. So the commonest, what is an ulcer? What is duodenal ulcer? What is an ulcer? Cut in the mucosa, and then it goes deeper, might penetrate through the wall and start eroding the artery that is, and will cause bleeding, right, in severe cases. Okay, and also what do we have? We have the lesser sac, we have the gastroduodenal artery, bile duct, portal vein, and inferior vena cava. Superior to it is the epiploic foramen, and inferior to it is the pancreas. Now again, if I let the liver go down, the quadrate lobe and the neck of the gallbladder will be in touch with the first part. Now, pay attention to this. Now this is the stomach, what is left of the stomach, and what is this? Pyloric sphincter, which is a physiological or anatomical structure. It is anatomical. You can actually feel it thick. There's thickening of the smooth muscles, right? And then there is the duodenum, and this is the first inch, and this is the second inch. Any difference between the first and the second inch? What? Don't look at me, look at the, what is it? Folds, right? First part of the duodenum has no mucosal folds. It's called the duodenal cap. And then mucosa will start folding. We call that plica circularis. And then the mucosa, these folds become thick. When you fold things, why do you fold things? Because you want to increase the surface area. Why do we need to increase the surface area? For digestion and absorption, right? The first inch of the duodenum has no folds. You know what is barium? You know, barium is a substance we ask the patient to swallow, and it will be excreted as is, will not be absorbed. And as it goes down, we start taking x-rays, so that we see the contour of the... So once the barium, this is the barium, that's the esophagus. What is this? Air in the fundus of the stomach, right? You eat, then air goes up. And you can see it without even the barium. You know, take an abdominal x-ray, you will see gas there. You know this is the fundus of the stomach. This is the fundus, this is the pylorus, and this is the duodenal cap. Nice, smooth outline, no problem. The moment you start going down and there is plica circularis, or the folds of the mucosa, then this barium will be broken. You know, it's going to look something like this, right? Like this. It's not as smooth as this, right? So this is, you know, we are in the duodenal cap because, you know, barium is still nice, smooth outline filling the space. Okay, second part of the duodenum is 3 inches. And you can see it is running in front of this. What is that? What is this, guys?
Right kidney. The what?
You had a renal block. La alaykum. What is this, you guys? Right kidney.
Yes,
And then it is in front of the hilum of the kidney. What do we have in the hilum of the kidney? What is hilum or hilus? Middle is the entrance and the exit. You know, this is where structures enter and leave. Examples of structures that will enter like what? Renal vein, renal artery. Structure of the example of structure leaving the kidney, ureter, right? Anyway, so it is in front of the right kidney and the structuring entering and leaving the kidney. And anterior to that, you can see this line here. What we said, this line is the line of attachment of the transverse mesocolon. Remember, you have to remember this. You cannot call a structure a mesentery unless it is attached to the posterior wall. Okay? Then, because we're going to study the appendix 2 lectures from now, I'm going to say appendix has a mesentery. But it is a false mesentery because it is not attached to the posterior abdominal wall. Anyway, so this is the second part of the duodenum. Anterior to it is the transverse colon, transverse mesocolon. And if I let this, again, the liver and the gallbladder go down, you know, it's going to be the liver and the fundus of the gallbladder will be in touch with the second part of the duodenum. I just wanted to remind you that into the second part of the duodenum we have the hepatopancreatic ampulla of Vater, which is basically the pancreatic duct and the common bile duct, surrounded by this sphincter of Oddi, and this, you know, the bulge inside the duodenum is going to create a major duodenal papillae. If you were to have an accessory duct, that is, you know, it's going to create the minor duodenal papillae. But this is, it goes into the second part of the duodenum. Third part, easy, from psoas muscle to psoas muscle, is going to cross the inferior vena cava, it's going to cross the aorta, and it's going to reach the second. You know, whenever you say psoas muscle, remember this. By default, what is running on the psoas muscle? By default, always. Ureter. Okay, so this is the third part of the duodenum. What is crossing the third part of the duodenum? What is this line here? You can see 2 lines, one, the other line. This is the line of attachment of the mesentery of the small intestine. Tomorrow we're going to discuss that. The 6-7 meters of the small intestine, you cannot afford to have them floating and playing in your abdomen. So you're going to bring them together and attach them to the posterior abdominal wall. It's going to be called the root of the mesentery. So this root of the mesentery is going to cross the third part of the duodenum, and within that you can see these 2 arteries that we'll discuss frequently. This is the superior mesenteric artery, and this is the superior mesenteric vein. Did I miss anything? Okay, no. Final slide, alhamdulillah, which is the last part of the duodenum, is the last inch of the duodenum. Because this is the duodenum, and then it's going to move forward, it's going to be directed forward so that it joins. What is after the duodenum? Duodenum. So duodenal junction. And you can see it fixed in place by this. This structure is a peritoneal ligament. It's called ligament of Treitz. And it is attached to this. If you don't know this, I will never teach you again.
Right
Cross of diaphragm.
You had a CVP block.
Yes.
What is this?
Curse of the diaphragm. Right curse.
Right cross of the diaphragm. Next time I'm going to remove the text from my lectures so that you don't cheat. Okay, so this ligament of Treitz, it fixes the last part of the duodenum, and it is attached to the right cross of the diaphragm, and you can see, you know, medial to it, that is the aorta, and behind it, that is the vertebral column. What do you have after this? Genetics? Dr. Zuhair? Very nice guy, I like him. Any questions? No questions? No questions? You're usually that quiet? Inshallah. Anyway, good luck.